believe is dialogue number 213. We have a very distinguished visitor, and I'm going to ask Dr. Mike Huber to introduce her, and we can begin the proceedings. Gina, thank you again very much for being here.
Thank you, Ken, and I'm thrilled to have Gina Piscitello, my friend and colleague, here to give what I'm sure will be an amazing talk. Dr. Piscitello is an assistant professor of medicine in the Department of Medicine, Division of General Internal Medicine, Section of Palliative Care and Ethics at University of Pittsburgh. She's a clinician, palliative care clinician, and a clinical ethicist there. She completed her undergraduate studies at Northwestern Medical School at University of Minnesota, and internal medicine, hospice, and palliative medicine fellowship and ethics fellowships at University of Chicago, along with a master's in clinical research at Rush University. She's interested in research at the intersection of clinical medical ethics and palliative medicine, focusing on disparities in serious illness care, including clinician-patient communication and decisions to withhold or withdraw life-sustaining treatment. What Dr. Piscitello is too humble to write in her own introduction is that she is a tireless advocate for equity and someone who calls out disparities when she sees them. So I'm really looking forward to this talk.
Thank you, Mike. Thank you, Ken. I'm going to share my screen, and I'll try to keep the chat up. I don't know if I can always see it when I have the PowerPoint shared. So just, if you want to unmute yourself ever, that is totally fine with me too. Okay. And here we go. So the topic today is disparities in clinician decisions to withhold and withdraw life-sustaining treatment. So my plan is to first talk about what disparities exist in these decisions, describe reasons why those disparities may exist, and then identify mechanisms to help improve these disparities. To begin, I want to talk about a patient case. This patient is in their 30s. They have decompensated liver cirrhosis. They're admitted to the ICU with hepatic encephalopathy requiring intubation, hypotension requiring vasoactive agents, hepatorenal syndrome. So they're there for weeks in the hospital. No one thinks that they're going to ever leave the intensive care unit. They can't get better. The clinician explains to the patient's surrogate, the patient can't speak. The clinician explains to the patient's surrogate that acute continuous renal replacement therapy will not be provided to the patient because, in their medical judgment, the harms of this treatment outweigh the benefits for the patient. So the patient, their kidneys are failing because of everything else that's going on. The thought is that if you put them on this treatment to help the kidney failure, to clean out the toxins from the blood, the patient's blood pressure is going to drop too low and they could maybe have a cardiac arrest. So the clinician, in their medical judgment, they believe the harms outweigh the benefits. And they're just telling the surrogate, we're just not doing it. But the surrogate disagrees with this, and they request that the patient receive the CRRT treatment. So I just want to kind of put this case into your minds, because this is a case of potentially inappropriate treatment. This clinician thinks, in their medical judgment, the harms outweigh the benefits. The surrogate saying, I disagree with you. I don't think so. I think when we see these disparities that I'm going to show you that exist in our decisions to withhold and withdraw life-sustaining treatment, this is kind of a situation that comes to my mind is, depending on what patient or surrogate is at the table for this discussion, as clinicians, are we different in when we decide to do these unilateral decisions? For some people more than others. So think about a case like if this patient surrogate, if they were a lawyer, would I be less inclined to just tell them we're not going to do this treatment? Or this patient's surrogate has been someone who they don't speak English, and they have, they just seem, when I have the interpreter, conversing with them, they always agree with whatever I say. Would I be more likely to withhold this therapy in those situations because that surrogate has been seeming to, agree with me on everything through the interpretation of an interpreter? I think these situations, I know personally, I can speak personally, I think when I'm worried about conflict occurring, I worry that I myself am less likely to kind of make recommendations in this kind of a situation than in other situations. So just keep this in mind as we go through. Part one is actually telling you about disparities that exist in these decisions. All of these studies that I'm going to show you three. They're all from 2023, so very recent data. The first, I'm going to talk about withholding ECMO. Second, I'm going to talk about withholding mechanical ventilation. And third is about withholding CPR. So the first study from 2023 is disparities in adult patient selection for extracorporeal membrane oxygenation in the United States. So ECMO is a form of life support for either lung failure or heart and lung failure that can literally keep people alive who, without this therapy, they would be dead. I include this picture up here. This is from Rush, and it's like public. It's like part of the advertisements for Rush. So, there's consent and everything for this picture. But ECMO is like a miracle thing. It is absolutely amazing to be involved in these patients' care. People who are put on it who would otherwise be dead and then come off, like it is just absolutely amazing. So this is a picture of this man who eventually came off ECMO. This was during COVID. He's out on our Rush balcony. That's the background of Chicago and the skyline. And he's just having a great time. You can see all the staff that's required for ECMO. Those big tubes that you can see, those are all taking his blood out of his body. It goes through the machines to clean out, remove the carbon dioxide, provide oxygen, and then it goes back into the body. But it's an extremely intensive resource because you need not just like the bedside nurse that's there in the intensive care unit, but also an ECMO tech, a very big multidisciplinary team helping care for the patient. You can see like physical therapists are there as well because they're trying to walk patients on ECMO. So it's a really great thing that we do, and it can really benefit many people, but there are disparities in who we provide it to. So this study was looking at using multiple different data sets. Where are we less likely to give patients ECMO? And overall, what they found is that female patients with Medicaid, Medicare, other insurance, so people who are uninsured, people from the lowest income neighborhoods, and then people who are Black, they are less likely to be provided ECMO. So looking at these different data sets, so one data set they used is this nationwide readmissions data set, looking from 2016 to 2019 at over 18,000 ECMO cases. And the data here that I want to show you is that the odds of giving a patient ECMO, a female patient compared to a male, is 0.73. Looking at insurance here, the reference group is private insurance. For Medicare, 0.5. Medicaid, 0.55. Other insurance, 0.64. And then when we look at medium income of patient zip code, the quartile, so the lowest, quartile 1 is the lowest quartile of patient income. You can see the odds, the lower the income you go, the less likely you are to receive ECMO. So that's this data set, this nationwide readmissions data set. They also use state inpatient databases, which also included race data. That last data set I showed you didn't have the race data. They found basically the exact same thing, except they also were able to have race data here that showed Black patients are less likely to be provided ECMO. Same thing, female sex, people with other insurance than private insurance, and then people who are the lowest income are less likely to receive ECMO. They looked again at, maybe it's just that these people who are like Black or female or low socioeconomic status, they're just going to hospitals that don't provide ECMO. And that's what the disparity is. They're just not presenting to these ECMO capable centers. Even when you look at the ECMO capable centers, within those centers, these exact same disparities exist. So with this data, looking at it multiple different ways, the same groups, female, Black, low income, people with Medicare, Medicaid, other insurance, they are less likely to be given ECMO. Now, this data doesn't prove that clinicians are like having, they're the reason for these disparities. Maybe female patients just don't want ECMO, but maybe they actually do, and the clinicians are just somehow biased in some way in thinking about the patient when they see that patient in front of them to provide this resource to them. So there's a lot of, this is just showing that there is a disparity. The next step is we need to figure out what's actually going on. There could be a lot of things that are going on. One thing I want to mention here is that for people with other insurance, one reason why ECMO might be used less is when you put a patient on ECMO, like you want them to come off. You need to, you're going to put them on it. You don't want to keep them on it for a year, which, many hospitals, people are on ECMO for a year, and that's something that can be very intensive, resource intensive, contribute to moral distress. This like ECMO, a bridge to nowhere where people are just on ECMO and they can never be liberated from it. People with other insurance, I do wonder in clinicians' minds, are people thinking, well, a lot of times if people aren't put on ECMO, transplant potentially could be an option. If you don't have insurance, is transplant an option? Most of the time it's not an option. So is that kind of going on behind people's minds, is that, for people with other insurance, they're less likely to provide it because they think the patient might be less likely to be able to get off of it. Some data that we have is that we know in the US from multiple different studies, about 17 to 30% of organ donors in the US, they did not have health insurance. So these people are donated organs, but they don't have health insurance. Now, while they're allowed to donate to other people without insurance in the US don't really receive organs. So only 0.8% of uninsured patients actually receive an organ transplant. So in the US, we have this huge ethical issue here where we will take your organs if you're uninsured, but you're very unlikely to receive them in the US. Moving on to paper number 2, this is looking at invasive mechanical ventilation and disparities that exist with providing invasive mechanical ventilation. So this study looked at patients. It used time varying variables, so like oxygen levels over time, vasopressor levels over time, looked at patient comorbidities. They tried everything that they could using multiple different data sets to look at patients who were requiring invasive mechanical ventilation and were they provided it or not. And what this study found overall is that patients who were Asian, Black, and Hispanic were less likely to receive invasive mechanical ventilation when compared to white patients. When you take into all these other factors, all these other patient factors into account, they did this really interesting study where they looked at if you were to provide invasive mechanical ventilation at the same rate to white patients. So if you had a Black patient and you gave it to them the same way that you would for a white patient, what would patient outcomes look like? And what they found is that the sickest patients, so on the bottom of this graph, it's the measure of oxygen. So if your measure of oxygen is 1, you're being provided 100% oxygen, these are the sickest patients. And what this study was doing in their simulation was they're finding that if you actually provided intubation for people of color at rates similar to white patients, those sickest patients, it's likely that they would have a lower odds of dying if you were to provide them invasive mechanical ventilation at these higher rates. Now, the interesting thing with this is that they also found if you were for these less sick patients to provide mechanical ventilation at the same rates as invasive mechanical ventilation to the patients of color as white patients, you might actually be more likely to increase mortality for these groups. So the rates for invasive mechanical ventilation, they are different across race. If we just try to make it equitable across race about like how we're giving mechanical ventilation invasive for these patients, we might actually create disparities in outcomes. For the sickest patients, we might actually improve mortality rates, but for the less sick patients, we might actually exacerbate disparities. So, and let me tell you for the in the chat from Jen, Medicare is considered as not having insurance. Medicare is insurance, so that was a separate category. The other category was basically like no insurance. So everyone besides people with Medicare, Medicaid, or private insurance was that other group. This third study I want to show you is disparities in unilateral DNR use during the COVID-19 pandemic. And this was a study that we conducted in Chicago at 2 different academic medical centers. It looked at 14,000 patients who were admitted to the intensive care unit during a 1-year study period during the COVID pandemic. They were all on vasopressor agents. So these were like the sickest of the sick patients in the intensive care unit. Looking at all of these patients, we wanted to look at the rate of unilateral DNR orders and DNR orders across the different waves of the pandemic. In Chicago, we had 2 big waves of COVID that occurred April 2020, and then again in like November, December 2020. What you can see here is that our rate of unilateral DNR order use dramatically increased during those waves of the COVID-19 pandemic, where our rate of DNR orders in general did not. What the difference is between a unilateral DNR order is and a DNR order is the unilateral DNR order is decided by the clinician. It does not require consent from the patient or surrogate to put that order in. So these are decisions where the clinician, and at both these hospitals, they had policies that said, if the patient's on maximum life support, they are going to experience an expected cardiac arrest, and the cause of that cardiac arrest, you are certain you cannot reverse. In that situation, you can put a unilateral DNR order in that you need to inform the patient and surrogate that this is going to be put in, but it does not require their consent to do so. So the DNR orders, those had patient or surrogate consent. The unilateral DNR orders did not require patient or surrogate consent. So looking at who do we do these unilateral DNR orders on, there were differences in who we did them on. So the big things here, when we look by race, for Hispanic and Latinx patients, almost 8% of all patients admitted to ICU who were Hispanic or Latinx had a unilateral DNR order placed. When we look by language, almost 10% of people who were primary Spanish-speaking patients had a unilateral DNR order in these intensive care units, which is dramatically higher than you can see for English-speaking primary patients. And then for people who were COVID-19 positive, they were more likely to have a unilateral DNR order as well. Now, we could just say that, maybe the patients who were Spanish speaking, they were just sicker. And that's why they were having these unilateral DNR orders placed, because they just met criteria more often for these orders. So we did a multivariable logistic regression model using these other factors to help kind of take into account severity of illness. to say like, are there still disparities even after accounting for severity of illness? And what we found here is that after we took that into account, Spanish-speaking patients still had higher odds of unilateral DNR orders than like other patients that we measured. The thing here is that when looking retrospectively at the patients who these unilateral DNR orders were used for, first of all, not everyone agrees that unilateral DNR orders should even be used. They were being used. And looking at the patients that it was used on, it was appropriate. It did meet the criteria of these hospital policies to be used. The issue is that there were other similar patients who also met that same criteria where it was not being used. They were allowed to remain full code, even though they were on maximum life support and going to experience a cardiac arrest from a cause that could not be reversed. They were not having these unilateral DNR orders placed, and that is where the disparity lies. Now, this could be that with unilateral DNR orders being used more often in Spanish-speaking patients, maybe it was just a communication barrier, and even with the use of interpreters, that it was uncertain whether the surrogate understood what was going on. So we just did unilateral DNR orders more often. I do worry, though, being kind of frontline during this the COVID-19 pandemic within our hospitals. Were the patients who are Spanish speaking just more likely to like have less conflict, or we perceive that they were going to be less conflict with us, and that's why we implemented these orders more often for this population, because we thought they would just not disagree with us, not like cause conflict. Whereas other patients who similarly met these criteria, were we concerned that they're going to get upset or get like legal involved, and that's why we're not using them in the same way. So also, I'm just showing you that these differences exist. I'm not telling you the reason behind it, and that's a really important area for future research. So I'm showing you that these disparities exist. Step 2 of this presentation is why are these disparities existing? So a lot of reasons. It could be related to hospital culture, racism, language, hospital policies, cognitive biases, laws, gender, religion, spirituality. There's a ton of things that could be playing a role in this. I'm just going to go through a few different reasons of what could potentially be contributing to these disparities. So first, clinician preferences. So this study that I'm going to show you, it's from the same, I'm going to show you 2 studies from the exact same data set of over 1,000 physicians. It was surveyed across the United States, and it was surveying clinicians about their preferences about unilateral DNR orders, life-sustaining treatment. And I'm going to show you that these preferences, they differ from clinician to clinician about their preferences for unilateral DNR orders and life-sustaining treatment. So first, about unilateral DNR orders, non-white physicians are much less likely to agree that unilateral DNR orders can ever be appropriate. So you can see here, Black, Asian, Hispanic, Latino, much less likely than white physicians to agree that unilateral DNR orders can ever be appropriate. So this, looking at disparities in unilateral DNR orders, if certain hospitals are much more filled with physicians of color, are they much less likely to provide unilateral DNR orders in their hospital compared to other hospitals? Also by specialty, big differences here. Family medicine, cardiologists, nephrologists are much less likely to agree unilateral DNR orders can ever be appropriate. So here the reference group is pulmonary critical care. They're the most likely to agree that unilateral DNRs can be appropriate, followed by geriatrics and hospice and palliative care right next to them. But the real difference is family medicine, cardiology, nephrology, much, much less likely to think that these unilateral DNR orders can ever be appropriate. So even within clinicians ourselves, there's a wide variety in like withholding life-sustaining treatment from patients, should it ever be done. Now, this same study population of the 1,000 clinicians that they surveyed, they also surveyed them about preferences for life-sustaining treatment. In this study, they found that for clinicians, they are more likely to accommodate a family member's preference for continuing life-sustaining treatment if that family mentions their Orthodox Jewish community. Clinicians are also more likely to accommodate sustaining life-sustaining treatment for a patient if a family member states the patient's religious faith does not permit disconnecting treatment. Now, here's where the difference lies. Clinicians are not more likely to accommodate sustaining life-sustaining treatment if a patient's family member mentions they are expecting divine healing. So here, what this data is kind of suggesting here is that if patients or family members are saying to us, I have this established religion, we as clinicians are more likely to accommodate that religious preference. But if a patient has or family member mentions a spiritual belief, not a part of an organized religion, just divine healing, as clinicians, we are not as likely, or we aren't statistically likely to accommodate that preference. So here again, we have disparities by religion. Are we more likely to provide life-sustaining treatment for people by religion? This data is suggesting that yes, potentially we are. Now looking at patient preferences. So, all these disparities that I showed you in the first part, maybe it's all that patients just have different preferences. They just, maybe Black patients and people, who are Hispanic, they just don't want life-sustaining treatment. This survey that I'm going to show you is showing you the opposite of that. So this study was done back in 2003. It looked at community dwelling older adults over 65 and asked them about their preferences for life-sustaining treatment. And what it found was that Black patients were more likely to want life-prolonging drugs and respiration at the end of life. So the reference group here is compared to white patients, and all the numbers that you see here are odds ratios. So if you look at the top of here, wants to spend last days in the hospital. Black patients, 2.3 odds compared to white patients, higher of wanting to spend their last days in the hospital. Hispanic patients, 2.2. Other patients, 2.1. Wanting life-prolonging drugs, you can see that for Black patients, they were more likely to want life-prolonging drugs than white patients. And then looking at wanting palliative drugs, Black patients, Hispanic patients, both statistically less likely to want palliative drugs at the end of life. So we had this large US survey that's saying certain patient populations, they want life-sustaining treatment more and are willing to accept it for longer periods when compared to white patients. So if you just look at this data, this would say that people want this life-sustaining treatment, and the disparities that I showed you showed, like with ECMO and with invasive mechanical ventilation, we're giving it less. So is patient preference is really the driver here? This data is suggesting it's not. Patients actually want this care, and we're potentially providing it to them less, which is a big issue. Now, this data exists, and this is just surveying patient preferences. I want to kind of show you some work that's being done now that kind of questions just the survey data and not taking it a step further. Because as I've been taught, in medicine, I have been taught that certain groups, they just want life-sustaining treatment more. And, Gina, you just need to honor those preferences. These groups want it more. To be respectful of these groups, we need to honor that. This study here kind of puts that into question a bit, or it just puts into question just sitting there with that statement and not pushing it further. This is work by Crystal Brown out of University of Washington, who's doing a ton of work on racism and serious illness communication. And in this study, she was predominantly interviewing patients in the hospital. They were predominantly younger Black men. And what she found was that these patients reported high levels of medical mistrust, high frequency of discrimination and microaggressions experienced in healthcare settings. Patients reported epistemic injustice as the most common manifestation of racism, silencing their own knowledge and lived experiences about their bodies and illness by healthcare workers. Patients reported these experiences made them feel isolated, devalued, especially if they had intersecting marginalized identities, such as being uninsured or unhoused. These experiences were associated with exacerbation of existing medical mistrust and poor clinician communication. Here's the big thing on this next slide that I want to kind of emphasize here. From their study, they say, our study findings suggest that Black patients who are multiply marginalized may have had values and preferences born from surviving unjust conditions and unequal relationships. So from her qualitative data, which is kind of what the patients are telling us, is kind of, I might be saying I want life-sustaining treatment more often than white patients. I might be saying this, but I am saying that because I do not trust you. I feel like I have to tell you this because the only way for me to get care from you is to tell you this. So for us to just take the step of, oh, well, people of color, Black patients, Hispanic patients, they just are more likely to want life-sustaining treatment than other patients. We should just respect it. Just respecting that preference might actually be perpetuating racism because their preference might be born out of, they don't feel like they can trust us as clinicians. And they have good reasons, in many ways with this data not to trust us. So they feel like they must say that to us, even if their underlying preferences might be different. They just feel like they have to say that to us to try to get equal care. So this is just this work that Crystal's doing. And I think just, to see where she goes from here, I think it's really important when we're talking about disparities in clinician decisions, because patient preferences, we need to figure out, how do we best respect patient preferences and acknowledge that racism is playing a role in the provision of care to patients, especially care at the end of life. Now, I want to talk about hospital policy, and this is a study that Mike Huber and I did together with a group, and it was supported by University of Miami. So this is a part University of Miami study. This is looking at how do hospital policies play a role in addressing decisions to withhold and withdraw life-sustaining treatment, including how do they address sociodemographic disparities in these decisions, which I showed you exist. So the study was done in July and August of 2023, so just last year. We had 93 different, sorry, not 23, 93 different hospitals across the United States respond with their hospital policy content. And what we found is that the hospital policies varied overall. Most hospital policies, 82%, if a patient or surrogate's requests withholding, withdrawing life-sustaining treatment, that will be honored. Most hospitals also said for physiologic futility, these are cases where it's truly care being provided truly cannot help the patient. There's a lot of wariness with this. Can you ever have something that's truly physiologically futile where it won't help a patient? An example of this would be potentially like a patient has a massive bleed and you cannot control the bleeding. Putting them on ECMO is physiologically futile because you cannot control the bleeding from a different source. That just can't. You could physically put them on ECMO, but they're still going to bleed out no matter what. That's a case of physiologic futility. So most of these policies honor that as well. If a patient has meets criteria for physiologic futility, then these life-sustaining treatments can be withheld or withdrawn, supported by policy. It's this potentially inappropriate treatment, and that's that case that I showed you at the beginning of the presentation. These cases where it technically can be provided and it technically might work, but the clinician believes that the harms to the patient outweigh the benefits. In this, what we found is that only 64% of hospital policies actually allow for this to be used. So there's something going on here that not all hospital policies agree with clinicians making these decisions where it's not true physiologic futility. It can be provided, but in my clinical judgment, I just think the harms outweigh the benefits. What we found is that when conflict occurs, these hospital policies address them differently. When conflict occurs, so when it's like a case like potentially inappropriate treatment, that patient I told you at the beginning about whether they should provide dialysis or not, there are consensus policy guidelines the consensus is from American Thoracic Society, CHEST, many different critical care societies came together to say, these are our consensus guidelines for if a patient, the surrogate disagrees with you withholding potentially inappropriate treatment, these are what you should be doing. We asked the hospital policies respondents who responded to our survey, does your hospital policy actually align with these consensus guidelines? Do they request that you seek expert consultation for additional assistance? Do they request that you get a second opinion? When the clinician says, I'm going to withhold this treatment, do you need that second opinion? Do you tell surrogates about their option to appeal the process? What we found overall, on the bottom of the screen here, the horizontal axis is the percent agreement. So overall with these hospital policies, for most of these things that we asked, less than 50% of the policies actually had that within their hospital policy component. I was just kind of surprised with the obtaining a second medical opinion. Only 30% of hospitals, if you have a surrogate who's really upset and conflicting with you withholding care from the patient, that only 30% of these hospital policies say that you should get a second opinion, or even less than that, recommend that you let the surrogate know they can appeal the process. That was kind of surprising to us. In addition, who's at the table to actually make these decisions? If it does need to be escalated before a committee, who's at the table to help with these decisions when the surrogate conflicts with a physician withholding care from the patient? And what we found is that the hospitals that have committees to discuss this potentially inappropriate treatment conflict over it, very few will allow the patient, surrogate, or family member to be involved in these conversations. In addition, very few, less than 1%, will allow a community member to be on that panel. You can see here, looking at representatives from diversity, equity, inclusion, people with racially, ethnically diverse backgrounds, less than 5% of these hospital policies require those members on these committees. So you have situations of conflict that may be occurring, and you're having hospital committees come together to discuss this conflict, but you're not letting diverse people you're not requiring that these diverse people be at the table for this discussion, which is a concern. We specifically asked, do your policies even address sociodemographic disparities in clinicians' decisions to withhold and withdraw life-sustaining treatment? Only 8% of these hospital policies even addressed it in any way. And the ones that did had opposing recommendations for what to do. So some hospital policies said, well, we should just totally exclude sociodemographic factors in decision-making. These disparities exist, but if we tell people that this patient's Black when we discuss them before a committee, it's just going to bias them even more. So just totally exclude it. Well, other hospital policies say you should actively acknowledge and incorporate these factors into decision-making. That we know that for ECMO, Black patients, female patients are less likely to get ECMO. So we should use that information, know that these patients are less likely to receive it, and factor that into decision-making so we can try to help improve equity in who we provide this care for. We found 3% of hospitals have policies that recommended collecting and maintaining information for patients for whom life-sustaining treatment was withheld or withdrawn that can be used to identify disparities in decision-making. So my concern is, I feel like these disparities might be happening at a lot of different hospitals. We just don't even know that it's happening because people aren't collecting the data. Only 3% of these policies, hospital policies, recommend collecting that information. And then finally, 47% of the policies that we assessed, they explicitly included clinician value judgments within the hospital policies. So some examples of this would be that the policy would say that, you could withhold or withdraw life-sustaining treatment if the treatment may offer no realistic chance of meaningful benefit, or the patient has no meaningful recovery, cure is futile, or the patient might have no interaction with their environment. So these policies, in a way, are actually encouraging clinicians to use clinician value judgments to support their decision-making to withhold and withdraw life-sustaining treatment. So where do we go from here? What can be done to improve these disparities? So just some ideas here. One is to encourage internal review to evaluate for disparities in these decisions. I can tell you personally, doing work in this area, hospitals do not like to give, sorry to say with a smile, hospitals do not like to give this data away. It is an extreme thing to get data from hospitals. Certain hospitals, when leadership finds out that you're trying to do an anonymous study, a multi-center anonymous study looking at disparities in decision-making, leadership will withhold that information. They say you cannot use this data for medical research, even when it's used in an anonymous fashion. I think it's a massive issue. I run into it at many different hospitals in trying to collect this data. So I think just, certain states, so for example, Texas, they have law that mandates recording of this type of data. I think I've shown you that disparities exist from 3 different studies. I am worried that disparities exist even on an even larger scale. We just don't even know that they exist because we're not being allowed to look at it. So it'd be great for like internal advocacy to be asking our hospital leadership, this is important. If we're going to provide equitable care to patients, we have to look at these disparities, if they exist or not. I worry though sometimes that just personal advocacy inside institutions, that might not be enough, and that we need like potentially state laws to help push us in the direction of, if we're going to provide equitable care, we have to look at the data. We can't just like not or ignore the data. I think that's one of the big steps that we need to take. Another step is increasing the diversity of clinicians to match the patient that we serve. So when we talk about that potentially clinician biases are playing a role in disparities in decisions to withhold and withdraw life-sustaining treatment, we know that the clinicians that are caring for patients, they oftentimes do not match the patients that we serve. There's multiple reasons for this. When we have clinicians that match the patients that we serve, there is data that suggests that when you care for patients whose backgrounds are similar to you, you might have less implicit bias against those patients. So there's data from multiple different avenues that say that, increasing the diversity of the clinician workforce, that might actually help improve disparities in care. In Miami, I took this picture, and I'm sure like many of you have seen this many times before. Every like city, it seems like, has their own map here. Disparities exist based on where you live, based on your race, ethnicity, disparities by, how long do people even get to live their lives? And just in short areas here, you can see that 86 years average life expectancy in, one area of Miami, and just like, miles away, it's 71. Massive disparities exist like this all across the United States. We could improve it if we, increase diversity of the clinicians that are in the workforce, but we're not doing it. This study, I think, was really like, it was difficult to read it. This is from 2023, data looking at medical school admissions from 2014 to 2019. What it's finding here is that people from lower socioeconomic statuses, so when you apply to medical school now, there is a question that says, what is like the parental income? Like when you were growing up from age like 0 to 18, like what was your parental income? And that is reportable. And to be honest, many medical students, applicants, they report that data on their applications. What we're finding is that each step that you go down, lower socioeconomic status, those applicants are less likely to be accepted. The most troubling thing from the study, from what I think from this study, is that from 2014 to 2019, if your parental income was $75,000 or less during the time that you were growing up, you were actually less likely to be accepted to medical school each year as the years progressed from 2014 to 2015 to 2016. We are actually becoming less equitable by socioeconomic status and who is accepted to medical school. So when you hear like all this, in the public, how, we want to expand diversity in medicine, we're doing the opposite. We're going the wrong direction. And I'm saying this I've been on multiple different medical school admissions committees. It's very difficult when you look at these applications, you're using like these test scores and like volunteer activities and, classes that people have taken to try to like compare applicants to one another. And, people, I genuinely believe this, people on these medical school admission committees, they are trying to be equitable in who they're accepting. We're not doing it though. Like we are going in the wrong direction. And so this is only going to potentially expand disparities in care that we provide to patients if this continues without being solved. I do want to say as well that certain medical schools in the US, they are somehow able to accept really diverse populations. So like UC Davis, there's a great like Stat News article. Multiple articles have been written about UC Davis, but somehow out of all these medical schools in the country, they can accept this really diverse, racially, socioeconomically diverse group of physicians that do well, but other medical schools in the US just really struggle with doing it. And finally, I wanted to mention promoting research to identify and reduce these disparities. We can't, number one, block data to look at it. We need researchers who have the skills and like methodological skills to be able to look at this data and accurately assess for these disparities. That data I showed you at the beginning, might you meet these real like strong researchers that say, well, I really disagree with how this study was done. And, I disagree with like this component of things. And that's important. Like those voices are important. We need to make sure that when we assess these disparities, we are 100% accurate in how we assess them. And that means training a research population to be able to, number one, be at the table to actually be able to look at this data and then do it accurately. I worry that when I show you that data about who's accepted to medical school, for clinician researchers, getting into med school is one thing. To become a researcher as a clinician is like a whole nother thing. It really matters on like who like what relationships that you have. I worry that, diversity in who these clinician researchers are as well, it is so difficult to go that path as well. And that's just another thing that we need to expand diversity and who's actually allowed to like have the skills, to do this work. People are passionate about it. We need to let people who are passionate be able to do that work and have the skills to do that work. All right, so in conclusion, I showed you that disparities in end-of-life decisions do exist. Multiple factors likely contribute to these disparities. And it's really important that we identify mechanisms to improve these disparities because they exist and we need to do something about it. All right. Thank you.
Really thought-provoking, great talk, Dr. Piscitello. Brought a number of questions to my mind, but I'll open it up to the audience first. Make sure everyone has a chance to ask questions if they have.
Well, in that case, thank you, Dr. Huber. Gina, thank you so much. It is rare to be able to say in the same sentence, what a wonderful talk. It was really dispiriting. There's a problem here, and it's a problem. I mean, all up in the People's Republic of Illinois may have different views about these things, but part of the challenge that we face in some jurisdictions is that very discussion of diversity and equity and inclusion are anathema. And in fact, I can tell you in Florida, it is a real challenge to be able to say, this is actually not advancing any kind. This is a clear-cut moral obligation. We've identified a disparity, therefore we need to address it. That actually seems uncontroversial in normal times, but in some places it's regarded as controversial. Have you encountered that when you share your results with others? How, in terms of other social determinants, how much of a significant one is it, do you think, when you look at political environment?
I think it's huge. Yeah. And I know, and I am not from Florida. I mean, I just see what I see in the news about what's going on. But like Texas, the same thing. But I think with Texas, what I find interesting is that Texas is a state, people have a lot of questions about what's going on in Texas, but they're the state that has mandated, you need to look at this data and see if disparities are existing. So to be honest, like, I think we can learn a lot, from how they're doing that as well. I think one of the things, like with Mike and I working on this project, what we learned from one of the lawyers that we worked with, Valerie Koch, is that for IRBs, that is required that you must have like a diverse group on a part of that IRB panel. And I was wondering, like in Florida, does that work? Are these federal regulations, is that enough to have to honor it? Because potentially like maybe federal regulations is the way to go for it.
If you, sometimes even when the right answer is clear, people need to be told that they must do it. It's an interesting challenge. But what you, in terms of the disparities you've identified about issues that, as you acknowledge, were tricky before we even worried about disparity, namely ECMO, which one could argue is overused. Two, non-beneficial or physiologically futile treatment. We were grappling with that before we realized that there might be a challenge here. What you've found is really quite challenging. What you and your colleagues and others have found is really quite, I should say, concerning, because if you're in the ICU, for example, and you say, look, my clinical judgment is this aggressive intervention is not going to benefit the patient. Why would they? I mean, the idea that that might be a conclusion that's reached more frequently for some patients by race or gender than others is really quite concerning.
Mhm.
So, Mike, what are you going to do about it?
Spend a career working on it with Dr. Piscitello leading the way. You know, I think one of the things that really struck me about some of what you were presenting is, you know, referencing Crystal Brown's interviews with diverse populations and how you can look at the data in some ways and this question of equity versus equal versus goal concordant care, and how it seems we need to look at this, and I completely share your call for sort of population level data. But then what's also hard is the understanding of this at the individual level, like we all do as clinicians. And I don't know if there are even ways to balance that or innovative ways to collect data where we're really understanding the nuance of what's a unilateral decision, where is shared decision making coming in. You know, we're noticing these trends on the population level, but how do you really understand that at the individual level? I don't know if you have any more thoughts on that.
Yeah, no, I think, and that's the biggest negative feedback that I get is, you know, you have this data, but like what's going on? Like, how do you prove what's going on? And I think from Crystal's work, like the qualitative data, like hearing from the patients, I think that's extremely important. But then you have a huge part of medicine who doesn't really believe like qualitative research is like an equal. So then like, are they really going to buy what you're doing there? I think we need to attack this from multiple angles, like, because we need to get those people to also think that this data is valid. You know, if people just think that this qualitative data is like worthless, then personally, I think I need that data to know what's going on. I think that's extremely important, but we're still gonna have a certain population within medicine who's gonna say like, that's not valuable. That's worth nothing. And then where do you go?
Yeah, Dr. Alladine, go ahead.
Dr. Piscitello, this was so brilliant. Thank you so much for giving this talk, and I really, really enjoyed it. Very enlightening, as Dr. Goodwin said, and very concerning, deeply concerning. But we've had a couple cases. I'm in the pediatric world. We've had cases that, you know, that these issues have come up. Are we treating one group differently from the other? And in some of our reading in the pediatric group, we came across this concept of social currency, right? And certain groups have a social network that can advocate for them when they're in these scenarios, whether it be religious group or just a community, an ethnic community. So in your research and in your reading, what do you think we can do to impact that, or what impact does that have on these disparities?
Yeah. And I think, you know, I feel like most clinicians, everyone does not want this to be happening. Like it's happening and they don't mean for it to happen. I think it's just they're not aware that it's happening. When you talk about like that social currency, I think if we all like had a sit down discussion with each other, we could recognize that this is happening. But for those patients, like nothing's like triggering us to say like, hey, you know, this other patient is the exact same, you know, medical situation as this patient with social currency. Why are you treating this differently? So I think what, you know, some people have suggested is like, do we need like a clinician nudge, like for clinicians to see their data on these are the patients that you're treating them differently, looking at the data. And then like for those situations to nudge them. For one of our cases with the unilateral DNR, there was a patient who totally met criteria and she was white. And we went to the clinician, we said, for these other patients, you're doing these unilateral DNR orders. She meets the same criteria. Why not her? And sometimes it's just that, it's not the forefront of our mind to think, oh, wow, these situations are the exact same. So I wonder if maybe clinicians just seeing those numbers themselves to see that, they personally are kind of contributing, and then it has some type of behavioral nudge to help improve it. I think these, clinician-directed behavioral nudges in many other ways of medicine, those are kind of helping to support disparities work. And maybe that's an avenue that could be used for this as well.
What I thought Dr. Aldean might ask is, has anybody looked at differences between adults and in pediatrics in terms of some of the trends you've noticed?
Yeah, I'm not sure. I think I'm so focused on the adult world. That's a really good point. Yeah. No, and I love in the chat about transplant, because that's totally true. I always worry, if I had to get a transplant, I would know the exact words to tell you to get the transplant. And that's so concerning, right? That certain people, they know the right words to say to get that heart. And other people, they just don't know it. And they say things that are, that is going to get them in trouble. And then what do? I know, as a palliative care clinician, when we see these patients, because anyone being evaluated for an LVAD, we have to see them. As a group, we've talked about telling the patients, please don't say that. If you say that to the transplant team, you're not going to get the heart. And so do we need to do that as a group, these patients with social currency, help build up the people without social currency to tell them that same information? Because the people with social currency, they just know the right words to say, as I would know the right words to say. I think it's a real area of moral distress, I think, for many of us. And then is it right for us to be telling the patients without social currency, well, say these words instead? I mean, that's kind of questionable too.
I think it depends. I mean, I don't tend to fill in the blanks for people generally, but you either have social support or you don't. So it's whether they know to say it. Do those people actually not have social support? Is everybody lying to a significant extent about their social support? To what extent are these parameters in place necessary? That would be another facet that would have to be explored. I mean, I just think that sometimes for the outcome sake, we weigh the benefits of whether or not something's going to be done. And that would definitely fall right along the lines and be absolutely discriminatory, just because there are other social determinants other than their immediate clinical presentation that, bear weight.
Dr. Piscitello, do you have the privilege of your pardon? I am full code right now if anything happens. Are you on an ethics committee? Do you work with ethics committees? Because one of the things that Mike and Amanda and I and the others here struggle with all the time is how to capture, mindful that these are challenging issues, and what Mike's done by starting to collect data about this, I think is exactly the right response. But what's your sense of other ethics services around the country? Is there mindfulness around this, or if you were a guy, if there were a meeting of ethics committee chairs from around the country, what would you advise them?
Yes. So it depends on the hospital. Just knowing personally, some of these hospitals are absolutely blocking it from their leadership. Others are looking at the data internally, doing good work with it, seeing that these disparities exist and making changes. They just won't allow that data to be public. So I think with this, it'd be very interesting to do a study, of all these hospital, ethics directors across the country of what are you doing? I think you need people at the table with very strong power to help get this data. There are certain hospitals, it's just you need the power to do it. And what I've seen, there's one hospital in particular, and I'm being very, cautious about what I'm saying here. I'm telling you the truth, but not telling you names here. But it was the clinicians of color who spoke up saying, you can't do this anymore. And it was a group thing that's what led to it. I think, you can see, and I've seen at other hospitals where individuals speak up and they say, well, we need a community member on our committee. We need this, we need diverse voices to be at the table for these discussions. And that one voice just gets lost. The things where it really works well are, I think, hospitals that have that mission for health equity. I mean, if it's in your mission, you got to do it, like, right? But I think other hospitals where other things are maybe more important to the institution, having that group of people with power, like a big group to advocate for it and just say this is unacceptable. But even in that situation, I have seen where it's still not worked, where people band together and it's still not getting that data. They are literally, I don't know of anywhere else in medicine where you block data. And of course, like, this is my area of passion, so I'm like into it, and I'm aware of it, but I don't know of anywhere else in medicine where would a hospital block you from accessing their data for research? Like, I just don't understand. This is hospitalized patients. Like, the patients wouldn't want their data blocked for this. Like, what would the patients think if they knew these hospital systems were blocking that? To just look for disparities. That's all, just look for basic disparities that exist. But what do I know?
We go to such trouble to get consent to do research on data, on as long as we think we like what the results are going to be.
Mhm.
Well, just Dr. Aladine's committee has a community member who happens to be someone with a disability. Does disability figure into any of the other cohorts that might have been studied along these lines?
Yeah. And I wonder, with the disability, how do you document that in the medical record for me to be able to pull that? I think, like, looking internally, we just had a discussion about this kind of internally for disabilities. Like, we're not documenting patient disabilities in the medical record. I think that's a huge area and that needs to be assessed. But I'd really be open to any ideas that people have here. How would you assess from the medical record disabilities? Like, what would you look at? The problem list? If they have like a good PCP, maybe they put it in the problem list, but what if they don't have access to a PCP? I don't even know where to look, or like ICD-10 codes.
During COVID, we did a study here at our large community hospital to see whether or not a crisis standard of care, which we adopted, that would have permitted unilateral DNRs, had it been triggered, would it have demonstrated some of the biases that you have documented? What we seem to have found is that it would not have. Whereas had we actually followed our crisis standards of care, it seemed to be that there would not have been disparities of the sort you identified. We never actually, never was invoked, in part because there was no support from the state capital to do such a thing. But the research we did was, therefore, as a hypothetical cohort, but it seemed to deliver good news. Namely, in some jurisdictions, you might find, I suppose, or this is just wishful institutional community thinking, that in fact you would, in the breach, actually not embed disparities in your clinical decision-making, which suggests about your research that a lot more of it is needed in a lot more communities.
Mm-hmm.
And I would caution that I think it was just luck based on the choice, because that same scoring system has shown disparities. But you're right that what it comes down to is matching the right scoring system to the right patient population and clinical parameters. I also would note that this was all hypothetical data, because in theory that process was never triggered at our institutions or your institutions. I wasn't here at the time, but the reality, and I think that's a big part of all this discussion about trying to get data, is the data is even much more complex than we think it is, because where unilateral decisions are happening and where we worry most about the disparities is, even if it's hard to call out, even if we see it, we're not even at the beginning of saying, in the case where we're all clear that what we're doing is not with the consent of the patient, we're not collecting that data. But then there's this spectrum of these conversations that are happening, and they're probably happening in different ways with different populations. And we might not even be aware that what we're doing is towards a unilateral decision or pushing for assent rather than consent, and how much the voice of one population of patients versus another happens. And so we can start with, the bare minimum of, the clear population-based data. And where we probably need to end up is examining individual clinician conversations with patients and understanding the process in greater detail.
Yeah,
And
absolutely.
as you mentioned, the documentation where we would look for disability, even our documentation, there's disparity in our documentation. I'm sure you know those studies where they looked at that maybe it was a COVID database, I think, that they looked at, I think it was female patients and Black patients were more likely to be described as challenging or difficult or non-compliant in their charts, which just carried over into every note that that patient had and therefore influenced how providers interacted with those patients. So even in our documentation, we may have disparities that will be challenging to pick apart.
Yeah, absolutely. And that's why I think like the disability part, I think I'm glad you guys brought that up, because that is, we're just missing them. Like it's a disparity. I can't even detect who they are to even look for it, which is really concerning. Yeah.
Dr. Huber, any last words?
What could be dispiriting, I'll try to end on a more spirited note. I've got less gray hair than Dr. Goodman, but I've been doing this for a little bit. And my sense, qualitatively, even if Gina's worried that no one believes qualitative senses, is that especially in the aftermath of the pandemic, just having these kinds of discussions, but also the interest of people in leadership of having and addressing these discussions has changed in noticeable ways that were different from early in my career. And I think we just need to continue to push that forward. But I'll let anyone else ask any other questions at the last minute. And thank Gina and Dr. Piscitello again for a really amazing talk.
One of the collateral damages of Zoom is that were you in person, you would be able to rely on a robust, enthusiastic round of applause. Thank you so very much for a wonderful presentation, Dr. Piscitello. Thank you for joining us in Miami.
Thank you.